Imagine, just for a moment, a healthcare system where something as simple as, say, a nagging itch could actually set off this whole cascade of anxiety, expensive tests, maybe tests you don't even need.
Yeah, a real rabbit hole.
Exactly. But now, flip that. Imagine a world where knowing what you need to do and when and why is, well, as easy as checking your phone. Today, we're not just scratching the surface, we're really going deep. This is a proper deep dive into the, let's face it, incredibly complex and often challenging world of healthcare in India.
That's right. And our mission today, really, is to try and unpack the systemic issues, the things that have been, affecting Indian healthcare for a long, long time, impacting millions of people every day.
So what are we talking about specifically?
Well, we'll be looking at everything. The really serious shortages in basic infrastructure, the frankly crippling financial costs that people face just trying to get treatment. Then there's the huge problem of misinformation, bad advice spreading around.
Which seems to be everywhere these days.
It really is.
Yeah.
And linked to that, a breakdown of trust. Plus, this kind of silent but honestly terrifying crisis of superbugs antimicrobial resistance. And crucially, we need to look at how all these different problems hit the most vulnerable people hardest, especially those who are illiterate, who just find the whole system impossible to navigate.
It sounds incredibly daunting. But you mentioned it's not all bad news.
No, definitely not. Because amidst all these challenges, we're also going to explore something genuinely revolutionary, I think. It's a patient-centered AI system called Dr. Maya.
Dr. Maya AI, okay.
And the whole idea is to try and flip the script, really, to empower people with knowledge, make medical advice clearer, and basically give them back some control over their own health.
And how are we approaching this? What are our sources for this deep dive?
We've pulled together quite a range of material. There's recent research, really cutting-edge papers painting a picture of what's happening right now. We've got government reports with the hard statistics. And maybe most importantly, we have these incredible insights from a pioneering doctor, someone who spent, 40 years?
40 years on the front lines.
Yeah, 40 years dedicated to trying to reform patient care from the inside out. His personal experiences and his drive are, a big part of this story.
Fantastic. So this deep dive is really for anyone listening who wants to quickly get their head around these big global issues, maybe find some surprising facts, and understand how technology, like this Dr. Maya AI, could actually lead to those aha moments, the kind that genuinely change how we think about things, maybe even change lives.
Exactly. We think by understanding these problems and the potential solutions emerging, you'll get a really unique view on how technology might forge a new path for global health. A more equitable one, hopefully.
Okay, let's start peeling back those layers then. Where's the best place to begin with this complex landscape? Maybe with the most basic thing. Just getting access to healthcare. The facilities. The people.
That's probably the best starting point, yeah. Because the scarcity is, it's stark. When you look at the official assessments, the picture isn't great. One government report we looked at actually described the public health system as being in critical condition.
Critical condition? That sounds serious.
It is. It revealed that 4 out of 5 public health centers across India fall below the standard. That's 80%. 80% of the basic health centers aren't really up to scratch.
Wow. 80%. That's a huge number. It signals some really deep problems right at the foundation, doesn't it?
Absolutely. And the staffing numbers, the human resources, they just make that picture even clearer. Back in, June 2016, the figures showed that for every 100,000 people in India, there were only about 76 doctors.
76 per 100,000.
Yeah, just 15 dental surgeons and 58 AYUS practitioners. That's the traditional medicine streams like Ayurveda, homeopathy, and so on.
Okay, let's break that down. One doctor for how many people?
Roughly one doctor for every 1,320 people, one dentist for over 6,700 people, and one traditional practitioner for about 1,700.
How does that compare globally?
Well, India's doctor density is less than 1 per 1,000 people. In most developed countries, you'd expect to see, well over 1 doctor per 1,000, so it's a significant difference.
And that must mean huge workloads for the doctors who are there. And long waits for patients.
Exactly. Overwhelming workloads, long waiting times. If you can even get an appointment, it's a massive bottleneck in the system.
And it's not just about the overall number of doctors, is it? It's also where they were located.
That's a critical point. This geographical imbalance is huge. The sources show that even though, what is it, about 72% of India's population lives in rural areas.
The vast majority.
Right, the vast majority. But around 80% of the doctors, 75% of the dispensaries, and 60% of the hospitals, they're all concentrated in the cities, in urban centers.
So the healthcare is where most of the people aren't.
Pretty much. This rural-urban divide isn't just a statistic. It's a life-or-death reality for millions. It means people in rural India often just don't have access to even basic healthcare nearby. Or maybe not at all.
I can't even imagine. If you have a chronic condition or your child gets sick suddenly.
You might be hours away from help, hours of difficult, maybe expensive travel. So many people are forced to travel long distances, adding to their burden, or they forego care. Treatable things become emergencies. It's a fundamental issue of fairness, of equity, affecting nearly 3/4 of the country.
And that lack of access, that geographical problem you mentioned, presumably that feeds into the next big issue, the cost.
Directly, it leads us straight into this other huge challenge.
Yeah.
The absolutely crushing financial burden of out-of-pocket expenditures. We call it OOP.
Oop.
And this isn't just, paying a small fee. It's a massive economic strain on households. Get this. In 2019-2020, almost half, 47.1% of India's total healthcare spending came directly from people's pockets.
Nearly half. So not from government spending, not from insurance primarily, but from individuals.
From individuals, yes.
Yeah.
Paying out of savings, daily wages, or going into debt.
And the consequences of that must be devastating.
They are. Truly heartbreaking. The figures suggest that every year, about 3% of the entire Indian population, that's around 38 million people, are pushed below the poverty line just because of healthcare costs.
38 million people pushed into poverty.
Yeah.
Every year.
Every year. It's not just hardship, it's financial ruin for millions.
Yeah.
Selling assets, racking up debt they can never repay, taking kids out of school. It's this silent drain on the whole country.
So what are people actually spending this money on? What are the main costs driving this?
Well, the biggest single chunk is pharmaceuticals. Medicines. That makes up a massive 40 to 50% of these out-of-pocket expenses.
Wow, half the cost is just the drugs.
Often, yeah. Then you've got diagnostic tests, like blood tests or scans, maybe around 10%. Consultation fees, seeing the doctor, around 13%. But here's something really striking and kind of frustrating.
What's that?
The non-medical costs. Things like just getting there, transport, maybe needing accommodation if you've traveled far. Those costs have surged. They used to be about 7% of the out-of-pocket spending 2 decades ago. Now they're up to 17%.
So nearly a fifth of the cost can just be travel and lodging before you even get treated.
Exactly. Imagine traveling for days, paying for somewhere to stay, all before you even see a doctor. That's a huge and growing burden, separate from the actual medical bills.
And this financial pressure gets worse because people often choose private hospitals, right? Even if public ones are cheaper.
That's a really important dynamic. Yes, many patients opt for private facilities, even though government hospitals might offer cheaper or even free services. There's this perception, maybe sometimes justified, maybe not, that private places offer, superior quality, personalized attention, faster recovery, better amenity.
So people feel they have to pay more to get better care.
That seems to be the driving force for many. And while you can understand why someone would want the best possible care, especially if they're really sick, this preference obviously makes the out-of-pocket cost problem even worse for individual families. It really points to maybe a lack of trust in the public system, or at least a perceived difference in quality.
Sounds like a vicious cycle. And does insurance help much? You mentioned a high percentage of spending is out of pocket.
Well, that's the puzzling thing. Even though apparently around 70% of the population has some form of health insurance, these significant out-of-pocket costs persist.
So the insurance isn't covering enough, or people don't know what it covers.
It could be a bit of both. Either the coverage itself isn't comprehensive enough, maybe high deductibles, lots of exclusions, or maybe there's just widespread confusion about what's actually included, so people get hit with unexpected bills.
Is there an example of that?
Yeah, there's data from Karnataka, a state in the south. Only about 28% of households there had health insurance for even one family member. Yet, private hospitals handled something like 66% of rural hospitalizations and a massive 81% of urban ones.
Wow. So even with low insurance rates, people are still overwhelmingly choosing the expensive private option.
Exactly. It suggests that even when insurance is available, it's either not sufficient, not trusted, or people are still driven to private care for other reasons, leading right back to those heavy out-of-pocket costs and the financial strain we talked about.
Okay, so we have issues with access, with cost. What about trust? And information. That seems to be another major strand here.
A critical one, and perhaps, even more insidious in some ways. We're talking about misinformation, deep-seated distrust, and what one of our key sources, that pioneer doctor we mentioned, describes as widespread unprofessionalism.
Unprofessionalism. How so?
We'll start with the patients, especially
Yeah.
the huge number of people in India who are illiterate. For them, the lack of timely advice, the lack of information they can actually understand, makes controlling the spread of infections, for instance, almost impossible, according to Dr. Srivatsa's account.
Because they can't read health advice or understand prescriptions.
Exactly. Imagine not being able to read a pamphlet on hygiene, or understand the dosage on a medicine bottle, or tell credible health advice from dangerous nonsense. This isn't just an inconvenience, it marginalizes them completely. They're left vulnerable, relying on word of mouth, or worse, falling prey to people selling fake cures.
And this doctor, Dr. Srivatsa, he saw unprofessionalism among doctors too.
He did, and his accounts are quite personal and alarming. With his 4 decades of experience, he shared some really troubling observations. He recounted finding doctors in hospitals who were, in his words, not honest, often rude, and unprofessionals.
That's a strong statement.
It is. And he wasn't just hearing stories. He personally witnessed poor patient management. Shockingly, he even experienced it himself when he was a patient. He talks about, for example, a relative whose condition was misdiagnosed because a doctor was overconfident, leading to a lot of unnecessary suffering. These aren't just isolated incidents in his view. They point to a deeper cultural or systemic issue.
And is there a sense of why this might happen? What's behind it?
Well, this is where it gets really concerning. There are documented worries that sometimes professional ethics might be getting pushed aside by financial pressures within the institutions. The suggestion that doctors might be, quote, forced to follow protocols to increase cash flow by offering financial incentives to doctors to hoard wealth.
So doctors getting paid extra to order more tests or treatments, essentially?
That's the implication. A profit-driven model that could potentially prioritize generating revenue over what's actually best for the patient. Imagine going in with something minor, but ending up with loads of unnecessary tests, maybe a longer hospital stay, expensive drugs, all designed to boost the bottom line.
That would absolutely destroy trust if you can't be sure the advice you're getting is for your health or for their profit.
Precisely. It makes it incredibly hard, especially for vulnerable patients, to know what's genuinely needed and what's just generating income.
And alongside this, there's the problem of outright fake cures being advertised.
A huge problem.
Yeah.
And incredibly dangerous.
Yeah.
Our sources highlight this widespread advertising of, quote, non-medical school-trained alternate healthcare professionals claiming to cure cancer and practically every disease.
Wow. Curing cancer with no medical training.
The claims are often that sweeping and completely without scientific basis. They prey on desperation. Dr. Srivatsa felt so strongly about this, he actually investigated personally. He spent 4 months living at a place called Martuvam Healing Forest in Auroville, trying to see if there was any evidence for these kinds of claims being made by various practitioners.
And what did he find?
Absolutely nothing to support them. No evidence for the miracle cures being touted. And this experience, he said, was so disturbing that it compelled him to write a book called Nature Pharmacy.
Nature Pharmacy, okay.
Yeah, the whole point of the book was to counter these false assertions, claims made by some dietitians, some Ayurveda practitioners, natural healers who were operating outside of evidence-based practice. He wanted to provide verifiable information, to emphasize how critical it is to have reliable sources in a world full of this dangerous misinformation.
It really shows the level of desperation people must feel to be vulnerable to those kinds of claims, and his drive to counter it.
It underlines the whole issue. People need reliable information they can trust.
Okay, so we've covered the complex issues of access, cost, trust, misinformation. Now let's shift to something you mentioned earlier, this silent pandemic of superbugs.
Yes, antimicrobial resistance, or AMR. And it's crucial to understand this isn't some random fluke, not a black swan event that nobody saw coming. Experts are clear. It's a predictable threat.
Predictable. How so?
Stemming directly from, as one source puts it quite bluntly, human inadvertence and stupidity. And this isn't just hindsight. Dr. Srivatsa, the doctor whose experiences we're drawing on, actually foresaw this crisis way back in 1989.
1989, what happened?
He witnessed the tragic death of a perfectly healthy 14-year-old boy from an infection that antibiotics just couldn't touch. It was resistant. And that experience, that personal tragedy, was a chilling warning sign for him of the global catastrophe that was building.
That's terrifying. So resistance isn't new, but it's getting worse.
Much worse. Resistance itself first showed up way back in 1940. Soon after penicillin was introduced, bacteria evolved enzymes to break it down. But here's the really scary part. Since the mid-1980s, we haven't discovered any fundamentally new classes of antibiotics.
No new types of antibiotics in almost 40 years.
Basically, no new classes. Meanwhile, bacteria are evolution experts. They keep adapting, swapping resistance genes between different species, like trading cards.
Yeah.
This creates these incredibly dangerous strains, resistant to pretty much all our current drugs.
Ugh.
We're running out of options.
It's like an arms race we're losing.
Exactly. We're fighting modern superbugs with outdated weapons.
So what's driving this resistance? Why is it accelerating so fast?
Several key things. First, just the sheer misuse and overuse of antibiotics. Doctors often feel pressured to prescribe them, even for things like cold or the flu, which are caused by viruses where antibiotics do absolutely nothing.
People expect them.
People expect them, sometimes demand them, and there's a statistic from the U.S. during COVID, over half the hospitalized patients were given antibiotics, even if they didn't have a bacterial infection. Every unnecessary dose gives bacteria another chance to learn how to fight back.
Okay, so overuse in humans. What else?
Agriculture. This is a huge one. Farming is actually the biggest consumer of antibiotics worldwide.
Really? More than human medicine?
By far. They're used not just for treating sick animals, but often routinely added to feed to make animals grow faster or prevent infections in crowded conditions.
And that creates resistant bacteria in animals.
Yes, like resistant salmonella, for example. And these bacteria don't stay on the farm. They can get into the food chain, into water sources through runoff, and because of global travel and food trade, these resistant strains can spread worldwide very quickly. What happens on a farm in one country can become a public health crisis on the other side of the planet.
That's deeply concerning. So human overuse, agricultural use, anything else?
Yes, the third big driver is simply poor infection control. Basic hygiene. Resistant bacteria spread easily from person to person if hygiene practices aren't good, if sanitation is lacking, if hospitals don't have strict enough protocols.
It sounds like stuff we should know how to do by now.
You'd think so. It goes back centuries. Think about Dr. John Snow and cholera in London. In 1854, he figured out it was spreading through a contaminated water pump. He took the handle off the pump, and the outbreak stopped. Basic public health detective work. Or Dr. Ignaz Semmelweis in Vienna back in 1847. He realized doctors were carrying something from autopsy rooms to maternity wards, causing deadly childbed fever. His solution: get doctors to wash their hands with a chlorine solution. Deaths plummeted.
But wasn't he ridiculed for that?
He was. Initially, people resisted the idea. It highlights this long-standing challenge. Sometimes the simplest preventive measures face the biggest resistance. And even today, basic hand washing, proper sanitation, good hospital hygiene, they're still not consistently applied everywhere, and that gives superbugs the perfect opportunity to spread.
So what kind of specific bacteria are we talking about? What are the dangerous examples?
Well, there's MRSA methicillin-resistant Staphylococcus aureus. It often starts as a skin infection, but can become deadly if it gets into the bloodstream. There's Bacillus anthracis, the cause of anthrax, known for its tough spores. Then there are various types of Mycobacterium.
Like TB.
Exactly. Mycobacterium tuberculosis, causing TB, is increasingly resistant to multiple drugs. Mycobacterium leprae causes leprosy. And Mycobacterium ulcerans causes this horrific disease called Buruli ulcer, which eats away at skin and tissue. These aren't just obscure infections. They represent a growing threat where our standard treatments are failing.
And the future looks pretty bleak if we don't get a handle on this.
The projections are dire, honestly. If the current trends continue, the estimates are that AMR diseases could kill at least 10 million people worldwide every year by 2050. Maybe even double that.
10 million deaths a year. That's more than cancer currently.
Yes, it would dwarf many major causes of death today. It would make routine surgeries like hip replacements or C-sections incredibly risky. Common infections could become fatal again. It's pushing us towards a post-antibiotic era. The WHO flagged this back in 2017, listing 12 bacteria as urgent threats, basically sounding the alarm globally.
This really puts the need for solutions into sharp focus, which brings us back to the healthcare system itself. You mentioned something called the elephant in the doctor's room.
Yes, this idea refers to the system's own contribution to the problem, specifically the over-reliance on consultations and maybe mismanagement within traditional healthcare.
How does that work?
Well, one part of it is what's sometimes called the worried well. People seeking medical help for relatively minor things that don't really need a doctor's intervention.
Like a cough or a headache?
Exactly. There was a UK example cited where something like 57 million GP visits a year were deemed unnecessary for things like coughs, headaches, sprains. That costs their National Health Service £2 billion annually.
£2 billion just on unnecessary visits.
Yeah. Think about that doctor's time, the clinic resources, all being used for issues that could often be managed with self-care or advice from a pharmacist, while people with genuinely serious conditions might be struggling to get seen.
And does this connect back to the trust issue? Why do people go to the doctor for minor things?
It definitely connects. It points to a broader issue with how healthcare is traditionally operated.
Okay.
Some sources argue that traditional models often prioritize profit over prevention. They can create what's described as manufactured dependency.
Manufactured dependency. What does that mean?
It means maybe systems are set up, intentionally or not, to keep patients reliant. By withholding information, using complex jargon, making systems hard to navigate, it empowers the professionals but disempowers the patient.
Making people feel they have to consult a doctor for everything.
Exactly. It erodes public trust because the system feels opaque, maybe even a bit intimidating. And when a real crisis hits, like a pandemic, that lack of trust makes it incredibly hard to get people to follow public health advice because they're already skeptical or confused. The knowledge gap has been widened.
And Dr. Srivatsa had specific concerns about practices that might worsen this, right? Like nurses prescribing.
Yes, he raised a serious ethical flag about the decision back in 2006 in the UK's NHS to allow specially trained nurses to prescribe medications. He observed that this seemed driven more by saving money and easing doctor workload economic pressures rather than patient safety, as he put it.
What was the problem he saw?
He felt it was irresponsible and dangerous because he personally witnessed instances where nurses, in his view, were misdiagnosing things. For example, mistaking viral infections for bacterial ones and then prescribing antibiotics when they weren't needed.
Which feeds right back into the AMR problem we just talked about.
Precisely. And he noted this seemed particularly problematic for immigrant patients who maybe had limited English and were confused about why a nurse was acting like a doctor. It raised serious questions for him about whether cost-cutting was unintentionally compromising care and worsening the antibiotic resistance crisis, a real ethical dilemma.
Okay, so faced with all these huge challenges, lack of access, cost, misinformation, distrust, superbugs, systemic issues, where does the hope lie? This brings us back to Dr. Maya AI.
Exactly. This is where Dr. Maya comes in as a potential new path, a solution designed specifically to tackle these problems by empowering patients and focusing on prevention.
So what's its main goal?
The core objective is really revolutionary in its simplicity. Act as a patient-centered guide. Give people the information they need to make informed decisions, fight back against that wave of misinformation, and importantly, take some of the pressure off the overloaded healthcare systems.
Shifting power back to the patient.
That's the heart of it, making them an active participant, not just a passive recipient of care that's often hard to access or understand.
And the name Maya, you said it had a dual meaning.
Yes, which I find fascinating. On one level, it stands for Medical Advice USS. Very practical, tells you what it does.
M-A-Y-A. Got it.
But Maya in Sanskrit also means illusion. And the idea here is to dismantle the illusion, as Dr. Srivatsa puts it, to believe only the doctors can save your life. It's about demystifying healthcare, making it less opaque, less intimidating for people everywhere.
That's a powerful concept. Does it connect to any broader philosophy?
It really does. It resonates strongly with ancient Hindu philosophy, which sees good health as fundamental to achieving your potential in life. There's a teaching from the Bhagavad Geeta mentioned. Deliberate on this fully, and then do what you wish to do.
So providing information, but respecting choice.
Exactly. It aligns perfectly with Dr. Maya's goal. Give people the knowledge, but preserve their autonomy, their free will. It also fits with the Ayurvedic principle that prevention is emphasized over cure, shifting focus upstream.
So it's trying to break away from what you called control-based healthcare.
Precisely. Where knowledge is power held by the few. Dr. Maya does the opposite. It offers transparency, makes information accessible through its really intuitive color-coded system, and directly challenges that knowledge monopoly. It gives people agency.
Okay, let's get practical. How does it actually work? You mentioned color codes and symptoms.
Right, it uses this very clear color-coded approach based on analyzing symptoms. But here's the clever part. It guides you to select 3 main symptoms.
3 symptoms. Why 3?
Because that mimics how experienced doctors think. They don't just look at one symptom in isolation. They look for patterns, combinations. A cough alone could be anything. But a cough plus high fever plus sudden chest pain, That pattern suggests something specific and urgent. Dr. Maya tries to replicate that pattern recognition using a triad of symptoms.
Ah, I see. So it's more sophisticated than just a simple symptom checker.
Much more. Many basic checkers just look at one symptom and have pretty low accuracy rates, sometimes less than 20%. By using this three-symptom triad, Dr. Maya aims for much superior diagnostic accuracy, getting closer to how a clinician actually reasons.
Okay, so you input 3 symptoms. What do the colors mean?
They give clear, immediate guidance. RDD is most urgent. Isolate and call doctor. Urgent evaluation. This is for severe symptoms, things getting rapidly worse, potentially life-threatening stuff. Basically, get professional help immediately.
Red means stop. Get help now. What about the others?
BLE is isolate and call NHS 111 nurse triage. This is for things that are semi-urgent, or if you suspect you've been exposed to something infectious but only have minor symptoms yourself.
Then the isolate part is important.
Crucial. The blue category actively encourages voluntary self-isolation. This is key for containing outbreaks early without needing heavy-handed government mandates. It empowers responsible action.
Okay, so red is emergency, blue is isolate and seek advice. What's next?
Yellow is for less urgent things. It might advise call NHS 111 nurse triage service for something like a persistent mild headache that's worrying you, or it might suggest speak to a pharmacist self-care if it's just, say, isolated mild pain that doesn't seem serious.
So yellow is seek advice or maybe self-manage. And green?
Green is the mildest category. Speak to a pharmacist self-care. This is for your typical common cold symptoms, things easily managed at home with over-the-counter stuff, or a quick chat with a pharmacist.
It seems very clear. Red, blue, yellow, green. Is it always that simple?
The system is designed to be intuitive, but it's also constantly being refined. They're working on making the definitions even more explicit, maybe adding interactive questions to really nail down the right category for each person, ensuring it's as safe and clear as possible.
Does it take into account the individual's health? Like if someone has other conditions?
Absolutely. Critical point. Yes, it does. This is a major difference from simpler tools. Dr. Maya specifically integrates risk factors, such as being older, say, over 60 or 65, being pregnant, being immunocompromised, maybe undergoing cancer treatment, having had an organ transplant, or having underlying chronic conditions like diabetes, heart disease, severe asthma, kidney problems.
So it knows that a fever might be more serious for someone with diabetes than for a healthy young person.
Exactly. It tailors the advice based on that specific health profile and vulnerability. It evaluates symptoms in context, which leads to much safer and more personalized recommendations. It's not one size fits all.
And you said this triad approach gives it better accuracy than checkers that just use one symptom.
Yes, the sources emphasize that. Those single symptom checkers often have worryingly low accuracy, maybe 19% to 54%. But Dr. Maya's three-symptom triad methodology, combined with the risk factor assessment, aims for superior diagnostic accuracy because it mimics that clinical pattern recognition. It's looking at the whole picture like a doctor does.
So what's the potential impact here? If this works as intended, what could it change?
The potential is huge, addressing so many of the problems we've discussed. First off, reducing the burden and cost on healthcare systems.
By stopping those unnecessary visits we talked about.
Exactly, helping people figure out, do I really need a doctor for this or can I manage it at home? That means fewer wasted consultations, less unnecessary travel, especially for minor things. And crucially, by guiding people to isolate appropriately, the blue category, it helps minimize the spread of infections.
Freeing up resources for serious cases.
Precisely. Focusing doctors' time and hospital capacity where they're needed most.
What about accessibility, especially in places like rural India?
This is where it gets really powerful for health equity. The app is designed to work on basic smartphones. Importantly, it can even work offline or with patchy internet connectivity.
Offline? How?
The core logic can be stored on the phone, so you don't always need a live connection to get the basic triage advice. This makes it usable in low-resource areas, helping bridge that rural-urban gap.
And can anyone use it? What about people who can't read well?
That's also been thought through. The intuitive, color-coded output is key. Minimally trained health workers, or people they call Dr. Maya advocates, can use the app to help guide others, even children or people in vulnerable communities who might not be able to use it directly. They don't need medical training themselves. They just follow the clear color guidance for referral advice.
And languages.
Yes, it supports multiple Indian languages. Kannada, Hindi, Tamil, Telugu are mentioned. Breaking down those language barriers is vital for reaching everyone.
That sounds incredibly useful on the ground level. What about a bigger picture, like spotting outbreaks?
This is another game-changing aspect. Think about all the data from people using the app, especially those landing in the blue category, potentially infectious cases. If you aggregate that data anonymously.
You could see patterns, clusters emerging.
Exactly. Dr. Maya enables real-time analytics. You could spot geographical clusters or unusual spikes in certain symptoms much earlier than traditional public health surveillance, which often relies on waiting for people to get tested or go to hospital.
So you could trigger alerts faster, maybe target interventions.
Precisely. Get alerts out sooner, maybe focus testing or isolation advice in specific areas. The potential is huge. One estimate suggests this early detection could reduce secondary infection rates by up to 40%. It's proactive surveillance, potentially stopping outbreaks before they explode.
And presumably it also helps fight the misinformation problem.
Correctly. By giving people clear, evidence-based, scientifically sound information, it acts as a direct counterweight to all those false claims from unqualified healers and fake cures we discussed. It's about giving people the truth.
Which aligns with why Dr. Srivatsa wrote his Nature Pharmacy book.
Perfectly. That book was about providing verifiable information to stop false claims. Dr. Maya is like a digital extension of that mission, empowering people with reliable knowledge to protect themselves from lies.
It really feels like his personal experiences fuel this whole thing.
Absolutely. You can't separate the technology from the human story here. His 40 years in critical care, seeing the system's flaws firsthand, even experiencing misdiagnosis himself as a child, battling against unethical practices. That's the engine behind Dr. Maya.
He saw things like profit motives overriding patient care.
He recounts witnessing that early in his career, seeing protocols that seemed designed more for financial gain than patient well-being. It clearly disturbed him deeply, and instead of just getting cynical, he channeled that frustration, that pain, into creating a solution. He wants to prevent others from going through what he saw or experienced himself. It's deeply personal.
So looking forward, technology like Dr. Maya is one piece of the puzzle. What else is needed?
Well, technology is definitely a key enabler, especially in places facing big infrastructure gaps. Things like the Internet of Things, IoT, using connected devices, maybe wearable sensors can massively boost health infrastructure.
How so?
By enabling earlier detection of problems, integrating test results automatically, relaying real-time patient data to doctors and nurses, it just makes everything more efficient, reduces errors, allows for proactive monitoring instead of just reacting when someone is already sick.
And what about treatments, especially for those superbugs?
There's exciting research happening there too. Scientists are looking into phytocompounds. These are powerful chemicals derived from plants. And also nanotechnology, using tiny particles to deliver drugs more effectively.
Plant-based chemicals and nanotech.
Yeah, they offer potentially innovative and novel ways to fight drug-resistant microbes. These approaches could be particularly promising for lower resource settings, maybe more affordable or accessible than developing entirely new classes of traditional antibiotics, which, as we said, hasn't happened for decades. It's about finding new weapons in nature and science.
So technology helps, new treatments might emerge. But what about the human side? Responsibility, trust.
That's fundamental. It requires a really profound shift. Healthcare can't just be the job of doctors and nurses or the government. It's a shared responsibility.
Shared by whom?
Everyone. Individuals making informed choices, policymakers creating better systems, health professionals upholding ethics, industries like pharmaceuticals acting responsibly. Even the agricultural sector has a huge role to play in tackling antibiotic overuse. Everyone needs to be part of breaking the chain of infection and building a healthier society.
And education seems key to that shared responsibility.
Absolutely paramount. Promoting preventive strategies, using technology like the internet or apps like Dr. Maya to spread accurate information about hygiene, about when you do and don't need to see a doctor for common ailments.
Cutting down those unnecessary visits again.
Yes, reducing the burden, saving costs, but also just empowering people. If the public understands more about common health issues, they can make better decisions for themselves and their families. It's about shifting from reactive sick care to proactive health care.
And rebuilding that trust we talked about.
That's the ultimate goal, isn't it? Moving away from a healthcare model that maybe felt like domination through fear, keeping patients in the dark, making them feel powerless, towards one that genuinely inspires trust and loyalty through understanding and compassion.
That sounds like a huge cultural shift.
It is. And it takes incredible resilience to push for that kind of change. Dr. Srivatsa's own journey really highlights that. The sources mentioned he faced torture, pain, and discrimination for advocating for ethical changes within the system he worked in.
Seriously, for trying to improve things.
Apparently so. It shows how entrenched resistance to change can be. But his story also shows that, as he puts it, breakdowns do create breakthroughs. His persistence, despite the pushback, is proof that individuals committed to patient well-being can drive transformative change, even against the odds.
It's quite an inspiring element to this whole story.
It really is. It grounds the technology in a very human struggle for better, more ethical care.
So this deep dive covering India's healthcare challenges and the potential of something like Dr. Maya AI, what's the main takeaway for someone listening?
I think the path forward is becoming clearer. It's about equipping you, the listener, with knowledge. It's about empowering you to, as Dr. Srivatsa urges, stop listening to lies, know the truth. It's about recognizing that you have agency in your own health journey.
We really hope this exploration has given you a clear, engaging, and, well, thoroughly informed view, cutting through some of the noise to give you a shortcut to understanding this really vital global issue and the potential for real, positive change.
So maybe the final thought to leave you with is this. In this age where we're drowning in information, yet often starved of reliable knowledge, where health crises seem increasingly complex, what is your role as an individual? How can you actively seek out and embrace tools like Dr. Maya or others that genuinely empower your own health autonomy?
And thinking bigger, what might happen if we all started doing that? If that collective shift towards empowered, informed patients happened across communities, across nations, how could that fundamentally redefine public health for generations to come?